All right. Well, good morning, everyone. It is 10 o'clock and we will go ahead and get started. If you are able to turn your cameras on, we'd love to see your little faces this Friday morning. I'm Lori Zimmerman, the Director of Professional Learning with MASA, and I am super excited to introduce to you Jen Murray today. Jen is coming to us live from Massachusetts, so we get a little scenic tour of the country when you log into informational sessions with us. Jen works with Effective School Solutions, and we met a couple weeks ago to talk about some of the work that they are doing to support mental health access for students in the schools that they serve. Everything from tier 1 to tier 4. So it's really interesting information, and I'm going to turn it over to Jen to continue to introduce herself and the work that she's doing. So thanks for being here with us today. I think you're going to enjoy it.
Thank you so much, Dr. Zimmerman. It's nice to see everyone today. As mentioned, I'm Jen Murray. I am the Senior Director of District Partnerships with Effective School Solutions. So that means I spend the bulk of my time talking to district and building leaders to really help them think about how they're addressing student mental health needs and the growing mental health needs that we're seeing day to day amongst our student population, and really see if we can kind of curate a partnership together that can really build upon what you're already doing to build capacity to serve more students. So with that, I'm just going to jump right in to the presentation. I will be answering questions, so feel free to use the chat if you'd like. I'll also open it up at the end if you just kind of want to unmute and have a few questions. That would be completely fine as well. There'll really be four parts of this presentation today. I'll start with an overview on Effective School Solutions, kind of who we are and why we exist. And then I'll talk specifically about the programs that we offer and how they align to the tiers of support that Dr. Zimmerman mentioned. And then I actually want to talk briefly about some of the strategies that some of our district partners have used to fund our partnerships, because as most folks on this call probably know, there is unfortunately not a line item for mental health services in school. So that is sometimes a barrier that districts have to face, and we want to be a partner with you in figuring out how to do that. Then I'll briefly talk about next steps and certainly open it up for questions. So just a little background on Effective School Solutions. We actually started as an outgrowth of a therapeutic day school in New Jersey. Cornerstone Day School is still thriving. We know that out-of-district placements can and should have their place in the education continuum. But our founder, Dr. David Nyman, was actually running Cornerstone at our inception, which was back in 2009. And he was noticing subsets of students that were landing at Cornerstone that really he felt could have been better served in their public homeschool district, if only they had the clinical capacity to deliver real clinical mental health support that, especially back in 2009, was really reserved for higher levels of care. So the idea was, can we support the two districts who are sending us the most students that kind of fit that profile and help them create that clinical capability within the walls of their school system? And so that's what we started doing. We're actually still partnered with both of those districts today. And I think because of that, we've really seen up close and personal how schools have grappled with the growing needs of students over time. So since 2009, I'm sure you're all aware, anyone who's been around since then will know that there's really been a stark increase in not only the number of students needing support, but the acuity of the mental health conditions that we're seeing in schools. And so we really wanted to help them to provide that capability within the walls of their school, but also expand the capacity so that they can do a little bit more of that preventative work, the kind of tier 2 work, tier 1 work, to really get ahead of this youth mental health crisis that we're seeing day to day. So I'll talk more about that as we kind of progress through this discussion. I will show you the MTSS continuum and really how our supports and services really align within that. But just again, kind of high level, Effective School Solutions started in New Jersey, and then we crept up the East Coast as far north as New Hampshire currently, and then across the country as well. So we're in California. We're now actually just entered our 10th state into Illinois. And we are kind of continuing to grow year to year by really responding to the needs that we're hearing from communities in districts like yourselves. So I think anyone that took the time to join me today knows that we are amidst a youth mental health crisis in our country. I am certainly sharing some data points with you, but I don't like to spend too much time really highlighting the doom and gloom of the situation. I think you're all seeing it every single day. One of the data points that I do like to highlight is on the right side, that last one down, 60% of the students 12 to 17 years old that have major depressive disorder are not receiving treatment. And that is a national data point. And so when we're looking at more specifically districts that are in more rural areas, I'm sure that number is even higher. And that really puts school districts kind of on the front lines of really taking on a different role in kind of addressing this youth mental health crisis. And schools are being asked to provide kind of a level of support that they were not necessarily designed to deliver. And so here we are today looking for how we can support you in doing that. I think one of the other interesting data points that has come out more recently is that students are actually 6 times more likely to access and complete a course of treatment when it's delivered at school. And again, that really is the kind of genesis of effective school solutions. We wanted to take a look at the way that schools were handling mental health needs and really compare that to the way that higher levels of care typically were addressing mental health needs. So things like out of district placements, therapeutic day schools, partial hospitalization programs, residential treatment centers, really look at that clinical model and see how we could adapt that clinical model to fit within all of the additional constraints that come with the public school setting. And we like to think of that as really creating kind of a perfect marriage of those two entities. But of course, that's a challenge because, as I mentioned, schools, and as you all know, schools were not designed to do this kind of work. They're designed as institutions of education, not really with that kind of medical model that can be necessary to support some of these higher needs students. Some of the barriers that we've heard from schools when they really try to tackle this initiative is that there really is a need for a defined model. Even if we have our own clinicians, what should they be doing? How often should they be doing individual therapy? Should we be doing family therapy? Is group therapy effective? Should we be doing CBT, DBT? So really the nature of what should that work look like? The need sometimes to actually have folks with that clinical expertise, kind of in comparison to what a lot of schools have to do, which is utilize their existing school counselors or even guidance counselors sometimes to try to address mental health conditions when they really might not have the experience or the training to deliver that kind of support. That there's a need for clinical supervision that often does not exist in a public school setting. That there's also a need for real specific protocols to guide the work for how you're going to support subsets of students. For example, students that are experiencing school phobia or chronic absenteeism versus students maybe that have a dual diagnosis of perhaps autism and a co-occurring mental health condition. So really those kind of specialized program capabilities. And the last barrier that we hear frequently is a need to really create a system for monitoring progress and keeping data safe and of course compliant with FERPA and HIPAA as well. All of these challenges are really kind of why Effective School Solutions is here, to really help provide support in overcoming those barriers. So all of our partnerships, when we partner with the district, they look a little bit different, all based on what each school district needs. But what you're seeing here are the kind of crux of what we bring to a partnership. First, it really is that actual comprehensive evidence-based programming. So looking at really defining the model of how frequently you're going to do individual therapy, family therapy, group therapy, really having a by design way to implement that and replicate it across schools and across districts. Also the hiring and finding the right staff with the right expertise. So that is a great amount of the work we're doing, especially these days with the kind of labor market, what it is. We are actually constantly seeking, recruiting, and building out our talent pool so that we do have people that really have that clinical expertise. And we also overlay with all of our partnerships, our quality and risk management team. So it's another team of licensed mental health clinicians that kind of supervise the work that is going on in our schools. We do provide that specialty care. So we have protocols that guide the approach we take with specific subsets of student profiles. We are a data-driven organization, so I'll be showing you data in a minute. And we want to make sure that when we're sharing data with school districts that we feel confident that we can replicate that kind of output and that program impact in districts across the country. And we do also bring the data storage. So all of our interventions are housed in an electronic medical record system, where it becomes part of the student's record. So the school actually owns it. It becomes part of the student's story of what the school and the district has done to really try and meet the student's needs. So all of these are components of partnerships, and really what the delivery looks like might be a little bit different. And I'll talk about that as I talk specifically about the programs, but this is kind of the background of what really kind of holds up an ESS program. So I'll switch from kind of high level who we are and what our mission is to really talk specifically about the types of programs we offer and really how they fit amongst an MTSS or multi-tiered continuum for those of you that might be using them. So we like to organize our supports and services along a continuum akin to what most schools and districts are used to using, whether they're using RTI or MTSS, but really looking at the kind of increasing the delivery, the intensity and frequency of interventions as student needs kind of grow through the tiers. One of the points I like to highlight, especially when I'm talking to my special ed people, is that we are actually not concerned with whether a student is identified as having special education needs or not. When we're looking at this continuum, we're just talking about the acuity of their mental health conditions. So our tier 3 students might be IEP students. They might have a 504, or they might not be identified at all, but they're your students that have the most significant need. So these are your students that need multiple clinical interventions throughout the day and throughout the week in order to access the continuum, the programming that you have, the educational options that you can avail to your students. I'll talk a little bit more about what that looks like, but just kind of big picture, we sometimes have our tier 3 program embedded in a wraparound model where students might matriculate to honors English first period, but second period is group therapy every single day. On the flip side of that, sometimes our tier 3 model is embedded in a self-contained program that might already exist, but really lacks that clinical kind of capability, that doesn't have any sort of comprehensive approach to how clinical interventions will be delivered, would kind of own that and embed that right into an existing program. Tier 2 programming is designed for students with mild to moderate mental health conditions. So these are students that before COVID, school districts really seem to feel pretty well resourced in supporting. So these are students that might be having weekly sessions with your school adjustment counselors. They might be accessing community supports if they are available. But the reason we've started really building into this tier 2 space is because we just are seeing over and over again the lack of availability of supports in the community. So students are having more and more barriers to accessing that level of care on their own, and then they're showing up in schools without their needs met, and then can quickly kind of titrate up to tier 3 without that level of support. So our tier 2 model is designed for students with more episodic needs typically. So they will kind of roll in and out of intervention time and ideally step back down to tier 1.
Yes.
When they're able to,
You can shut it.
or
Because I did tell them I was.
need to kind of scale up to tier 3, would have that capability as well. We also offer a crisis response and reentry program. We house that in tier 2 just because of the episodic needs of that student, but that is another area we focus on. So if your district is one that is having a lot of mobile crisis coming or having to send students to the emergency room for evaluations, we can actually embed clinicians into your district that can take on those assessments and make sure that only those students that really do need to seek a higher level of care really are ending up in those higher levels of care. For tier 1, we're talking about how we can bolster your capacity to support all students. If you were using SEL curriculum, would kind of house that in tier 1. If you were using a universal screener, would house that in tier 1. But the way Effective School Solutions primarily impacts tier 1 is through professional development and coaching with your educators, your existing clinical staff, and your administrative teams. So talk a little bit more about that as we get to tier 1. We've added, as you'll notice, this level of foundational support. We really just think that's critical, and making sure that you're not just kind of plugging one particular hole in your continuum, but you're really thinking about what should our continuum look like? Do we have entrance and exit criteria for each of these tiers of support? Do we know how students are triaged? Can we define what tier 2 looks like in one school and kind of compare that to what it looks like in another school. So it's really creating that vision, the action plan for how the district plans to move forward with building out their mental health continuum. Okay, so what you're seeing on this slide is the component parts of a tier 3 program. So what you'll notice is that there's multiple modalities. So our tier 3 students get individual therapy, they have group therapy, and they have family therapy, all delivered with different levels of frequency. Usually a tier 3 model will have a clinician fully embedded in the school, always. The clinician will be fully embedded in the school. So a partnership would be that we have any number of clinicians that are actually hired and supervised by Effective School Solutions. So we're finding the clinicians that have the right experience for the cohort we're designing a program to support. Those clinicians are fully embedded in the school. They're delivering a combination of what you're seeing on this page, but they're really available for any of those urgent needs that our tier 3 students have quite frequently throughout their day. So all of our tier 3 students have an individualized reset plan so that when they begin to feel dysregulated, they're kind of identifying what they're feeling in their body when that happens. We're helping to communicate that to their teachers to make sure that they are understanding how they might be able to help a student become regulated again versus potentially further encouraging the dysregulation by kind of increasing that trauma response. So ideally, a tier 3 program would have group therapy 3 to 5 times a week. Our clinician would run that with the students that have similar profiles to build that clinical capacity. They would have weekly individual therapy, and that is really driven by their individual treatment plan. So every student starts with a full biopsychosocial assessment. We can align that with IEP goals if their student is identified and has IEP goals. But we're really creating a treatment plan that's going to work to build coping skills for those underlying mental health conditions so that the student can then go ahead and access the academics that are available to them. They usually come back to our space for lunch, depending upon whether or not the students are in a kind of are in an inclusion setting or if they're matriculating. They might just come back and have lunch with us. If we're in a self-contained model, sometimes lunch is right there in the space. We work together with the districts to figure out what lunch should look like, but it really is another opportunity for our clinician to have an interaction with these students and try to get ahead of their therapeutic plan versus kind of having to be that reactive approach that becomes kind of all hands on deck and then pulls all of the capacity you have across the school. We do family therapy biweekly. So we actually invite families right into the school and we encourage that families to really be an active part in the treatment. This is especially important for students who are experiencing school avoidance or school phobia so that we can support the whole family system and getting that student to school. We provide family and caregiver support groups once a month for all of the families in our cohort as well. A lot of times our tier 3 students might have kind of frayed or fractured relationships with the school district just by the nature of the path that got them to where they are today. And so really building that more and more opportunities to have the families come engage with the school, be in the building and start repairing that information as part of the work that happens in those therapeutic support groups. We provide clinical supervision so that even though the clinician will be individually licensed, we still overlay multiple sets of supervision. There'll be a regional clinical director that supervises. And then, as I mentioned previously, our quality and risk management team that actually combs through our electronic medical record system, making sure that our clinicians are in fact keeping to the model. With fidelity. Also just have the availability to do a deeper dive if any of our students need a kind of a therapeutic review to kind of get a shift into their current programming. And again, the urgent interventions, our clinicians typically have whatever mode of communication schools are using. So often it's a walkie-talkie. And when a student on our caseload either has their head down, disengaged, or is acting out, our clinician would actually get that call and be the first line of defense for that real small population of students in a school that are requiring the most support to enable the existing resources you have in a building to do more of that tier 2 and tier 1 support. So as I mentioned, we are very data driven. What you're seeing on the left are the aggregate impact data for all of our tier 3 students last school year. So we had to wait for the whole school year to end, which is why we're not sharing the school year's data just yet. Overall, 94% of the parents of students in our cohort saw an improvement in their child's behavior and in the mental health symptoms. 95% of the students that we supported did not need a referral to a higher level of care. So they were able to be maintained in their home district with this level of support. A lot of tier 3 students struggle academically. On the whole, we saw 1 full letter grade increase of our students that are in a tier 3 program. We saw a 41% reduction in absences for students who are experiencing chronic absenteeism. And then we saw a 65% decrease in suspensions for students with a history of severe disciplinary incidences. So we actually share this data specific for each school district as well, so that you can really see the impact the program is having. What you see on the right is a little kind of sneak peek into our online dashboard. So administrators can kind of hop on and see what program utilization looks like, how students are engaging with services, and also any impact data that's available. That's tier 3. Our tier 2 program is really an adaptation of tier 3. So we started with tier 3. Essentially, that actually was ESS. The ESS program was just what we now refer to as tier 3. And again, as we noticed that need to offer a lower level of care to just help schools build that capacity, we've created a tier 2 adaptation. So tier 2, again, it's for students with mild to moderate needs. So in this model, a clinician actually does not have to be committed to just one school. They can support multiple schools because our tier 2 students don't need us multiple times throughout the day. They still start with a full assessment, just like a tier 3 student. We still have a treatment plan, but the delivery of interventions is really focused on weekly individual therapy and then monthly family therapy and caregiver support. We still will be able to push in if we need to for our students and respond to urgent needs throughout the day. But that looks a little bit different depending upon whether or not the clinician's time is split between multiple buildings or if they're just in one. So obviously, if they're in one building, they can kind of be available for any of those urgent needs that happen throughout the day. If they're not there, they can't be. So that's one of the kind of differences that you might notice in different tier 2 programs. Most schools that utilize our program for a tier 2 model have us kind of take on a specific cohort of students that they might be having a little bit more of a challenge to support. So maybe they're your kids that are a little reluctant to come into the school who need a lot of parent coaching. Sometimes there are students that might be more of the externalizing kind of behavioral students that are finding themselves being suspended. And maybe our tier 2 program is actually going to be a kind of suspension alternative model for students with a lot of anger management challenges. So we really kind of work together to curate what the kind of shape of the cohort will be to give the school the most capacity with their existing other resources. Also, as I mentioned, we do our crisis response and re-entry model. We house that in tier 2 as well. But that's really where we have clinicians embedded in a district. And instead of you having to call the community providers for any safety evaluations or safety assessments, actually our clinician could do that, see if students are presenting as being an imminent risk to themselves or others, and if they might need to go ahead and go to an emergency room for some higher level of care treatment. We also follow those students to make sure that the school understands what was recommended by the hospital or the program that they ended up being supported by, and making sure that there are some supports in place. And we could actually even carry a small caseload of support for students if they are on wait lists to kind of get them supported and have a transition back into the school day. Quick piece on professional development and coaching. So we offer a wide range of professional learning opportunities. We do classic kind of workshop-based learning opportunities. We have a library of over 40 mental health topics that really straddle mental health and education. Everything from kind of destigmatizing mental health for districts that just haven't done much on it yet, a lot on trauma, all the way up to things like doing CBT in group therapy in schools. So if you've got a team that's pretty well versed and you're just looking to really build out their capacity and give them some more tools, we can do professional learning for your existing clinical teams. We also can do a more comprehensive model for professional learning, where we actually come back monthly and support a cohort of educators in really putting trauma-informed practices or trauma-informed content into practice with job-embedded coaching. And we can also do something similar with administrators, who are really building their capacity to kind of look at how schools are performing through a trauma-attuned lens to build that culture across the district. We also offer clinical consultation, where we're actually kind of a thought partner with you on high acuity cases. And we could do kind of medical rounds models with any students that you're kind of thinking about. We kind of house that work in tier 1 as well, because it's not specifically focused on any one student per se. It's building the capacity of your team while also taking the kind of case study of an individual student. Okay, I'm going to transition to talk about how some of the districts that we work with are actually funding mental health programs, specifically our partnerships. Really what we're seeing is that most districts are using a blended or a braided approach to funding mental health initiatives. The first kind of bucket that we encourage districts to look in is really looking at how they might offset some of the existing internal expenses that you're incurring because you don't have enough mental health support. We'll talk more about that in a minute, but really it's looking at things like out of district placements. Are you trending kind of in the opposite direction from what you'd want and seeing those numbers grow over time? Maybe building a program like this would enable you to kind of reallocate that money back into your district to keep more students right there internally. A lot of our districts are using grants specifically for part of the funding. So we're encouraging every district to really look at what national grants and what local grants are available to you. State specific initiatives. So every state right now, it actually is quite surprising to me how the different level of engagement from states. I cover personally 6 states, and you'll see it's quite varies state to state with how much funding support is available through SEAs, but certainly we could be a partner with you in looking at that. Looking at Medicaid reimbursement. So if you already have a mechanism for securing Medicaid reimbursement, most of the services that we deliver for Medicaid eligible students are actually reimbursable. And so we can partner with you to make sure that you're getting any information that the district needs to make sure they're getting that Medicaid reimbursement. Utilizing title funds and IDEA. Because of the nature of our work and how much professional learning is really embedded, districts have been able to draw on Title II and Title IV funding to incorporate some of that to kind of help braid some of that funding that might be required. And of course, IDEA for any students who are identified with having special education needs. And then lastly, it's looking at local funds and general operating budget. We also add in here any residual ESSER funds. I know that we're really kind of ticking down the minutes that we can use that, but we are seeing districts really saying we have this small pot of money. How can we use it before it expires? And there's a lot we can still do over the summer, kind of as we gear closer to that September start date. Also, there are some opportunities. I'm actually not sure specifically in Minnesota to get some extensions on that, but if that was an area that you were interested in looking into, would certainly partner with you on that. We have a grants writing team that specifically works alongside our district partners to help them identify the funding and even sometimes apply for grants that might be available for using them. Just a quick look at some of the offsets you might think about and thinking about how you could fund a mental health continuum. First, as I mentioned, it would really be looking at your outside therapeutic placements. That ideally, you're not seeing the kind of number trend where you're having students go more and more students out. Hopefully that number has been relatively stable for you. We look at both cost avoidance of students that could have to go out of district without this kind of support. And also we're able to work with our district partners to help them potentially return some students from an out of district placement who could benefit from this level of support and perhaps access the curriculum with this kind of support in the program. Other offsets look at legal costs for settlements, looking at the costs that you might be incurring for hospitalized students to provide education or home instruction, perhaps over classification. A lot of districts also will have their highest level of mental health care tied into special education funding, which then, or special education programming, which can create a kind of bottleneck of kind of students waiting to be evaluated because the parents don't know what else to do and there's no other support available without kind of siphoning through special education. So looking at that cost, I mentioned Medicaid reimbursement as well, and perhaps any state specific initiatives around decreasing chronic absenteeism. Just what this looks like in real life. So 3 kind of case studies of how districts across the country have partnered with us, how they've funded it and what the outcome has been. So 3 we like to highlight. The first is Old Bridge, New Jersey. They were placing a high number of students in out-of-district placements, and they also had a high number of school avoidance students. So they brought in our Tier 3 program. They utilized IDEA funds, a combination of IDEA, local funds, and then also reallocating funds that were initially tied to out-of-district placements and transportation. With that, we were able to provide services to 46 students who are at risk or currently out of district, and that saved the district $4 million. Gilroy Unified School District in California, they actually had one of the out of district placements that they were utilizing close. So they were in kind of a panic with what to do with these students. They also brought in our Tier 3 program. They had 6 clinicians to support these students. It was funded by a combination of Medi-Cal or Medicaid for California and state and federal funding. They had 16 students that they were able to bring back into their home district, which saved approximately 1.6 million that they could then reinvest into their own internal continuum. And lastly, Ligonier Valley in Pennsylvania, they're a small rural district. They had a shortage of mental health services, and they brought in actually our Tier 2 model and utilized both the Tier 2 moderate intensity program and the crisis response and reentry model. They funded that with both budget reallocations and ESSER funds and a grant that they were awarded. The kind of result from that was that they reduced student hospitalizations by 86%. And that they were able to prevent 9 students from needing a higher level of care, which then enabled them to reinvest $135,000 into their own continuum. And just a few quotes of what folks from those districts, along with another in Sayreville, public schools have said about our program. I think it really speaks to, we tailored, what our student director of student services in Gilroy said, that we were able to tailor the model to really meet their specific needs in Gilroy. That we really were able to not only prevent students from going out, but also bring students back from out of district placements. And we only do that when that is the desire or the goal of the school. But we're certainly happy to partner in that. And lastly, that we're really able to, especially in Ligonier Valley, where there was just not that clinical support in the community, really bring that in to help students in a way that they hadn't envisioned being able to help them before. Okay, so that is actually the conclusion of the presentation. So some of the next steps I just wanted to share with you is that we will be sharing the slides. I'm not sure if they're already in the chat or not. They are, okay. So these slides are here for you. I will be at the Massa MACE conference in March. And I'd just like to offer everyone that's on this call, if there's interest, what we refer to as a complimentary mental health planning session or program consultation session. All of our partnerships start with a discussion, really learning about what your existing continuum of care looks like, where you might be feeling like you're falling short, where you feel like you're maybe really doing well, so that we can curate a partnership that can really build the overall capacity versus just kind of a canned, here's a Tier 3 program for you. So I would really welcome that conversation. My email address is here, my phone number. Happy to schedule that with any of the folks in any of the districts. At this point, I think I'll stop and just open it for questions if there are any, if that's okay, Dr. Zimmerman.
Yes, thanks so much, Jen. And thanks to those of you who are on the call. Oh my gosh, Sherry Johnson, I see your name. You should turn your camera on because I can't believe you don't have a question. I told Jen when we started that I anticipated that we would have some friends with some questions. So while Sherry's thinking, thanks for turning your camera on so nicely. You know, Jen, when you and I spoke, one of the things that stood out to me is kind of how you support tier one folks in the districts that you serve, and particularly support staff. Can you talk about that just a little bit?
Sure. Yeah. Yeah, that's been this year. I feel like that has been the biggest ask from school districts, actually, especially paraprofessionals. So all of our professional learning is delivered so we have, as I mentioned, like 40 topics that we can give you as a starting point, but we can really tailor those professional development content, the content in those workshops to meet different groups of professionals. So kind of meeting them with their skill level, with what kind of training they've had already. So yes, we've done a lot for paraprofessionals. I think we're seeing schools really struggling to fill those roles. And so
Uh-huh,
sometimes you have folks in those roles that really have not had much experience or education at all around
uh-huh,
student behaviors or student mental health needs. So we can certainly work with those with paraprofessionals. Ideally, we're actually working with the paraprofessionals and the educators together, so they really have a team, and
uh-huh.
really creating a common vocabulary with how they're talking about student needs in the classroom, and feeling supported with that. So we could do that in a series of workshops. So some districts plan out, say, quarterly workshop series with their staff, and we'll kind of have the same trainer come back and build on what they used each time. Or we could do something a little more comprehensive and actually get in the classroom, come in 3D in real life, and actually go in the classroom with them, give them the opportunity to put that into practice, ask questions, share any challenges they're having with the strategies they've learned so far.
And you also, I apologize if I missed this in your presentation, but you also support with MA billing. Is that correct?
With what?
With MA billing?
Yes, absolutely. Yes, we do.
So those were a couple of things that Jen talked about when she and I met that like, oh, how does that work? Or things that I found that might be super helpful. Questions from the group. If anybody else is able to turn cameras on so we can see your little faces, that's really nice. But Sherry, since I put you on the spot and I
Yeah,
saw that you unmuted, what are you thinking
I
about?
I did. Jen, I think one of the things that came back to me as I listened to the presentation, we have systems in place, but they're scattered and they're in
Mhm.
different silos. And taking this and we have to stop talking about title and sped and schooling to mental health. We've got to put it together as one comprehensive system. And then, like you just said, use the
Mhm.
same language. So that's something that is really a takeaway. It kind of brought me back to, okay, this is why we're struggling. Now I can think about how to talk about this in the spring. So maybe we can make some progress in the fall.
That's a
So I
really good
appreciate that.
point, Sherry.
Yeah, yeah, it is. Thank you for sharing that. It is, I think it's essential. And a lot of what we do when we work with that kind of foundational level that you saw on the MTSS triangle there, sometimes what that results in is what we call an MTSS playbook. And it's really for all of those non-academic needs. And it's kind of having it all together. You know what, you might have a BCBA doing that's kind of one type of support, but we also need to have all of the different non-academic supports kind of aligned in one spot so we know what's available. So we agree. We agree that we just need to kind of create that common language.
I think one of the other pieces that Jen and I talked about that was interesting to me is that continuum of services over the school year. We also know that sometimes at breaks or particularly summer break, like what do we do with those kids to support them during ESY when they don't necessarily have academic needs, but we know that they have behavior needs, they have mental health needs, and we know that when we send them home for the summer, those might not be met in the same way. Jen, you didn't share that 60% success rate or greater likelihood of completing programs. Like that's surprising to me. Even though
Yeah,
I see it every day, that was a surprising one to me.
me too. Yeah, it's alarming to see it, right? I think we all
Mhm,
kind of we have a feeling, but to see it's impactful. Yeah.
mhm. Other questions from those listening today? You are a quiet group. I'm sorry, Jen. I had
That's
like
okay.
62 questions when you and I met.
That's okay. That's okay. I just really appreciate everybody's time. If people have questions after or feeling a little shy and don't want to say it in front of the group, always feel free to email me or give me a call. Happy to answer any questions, or also just get to know what you're doing already and how we might be able to support.
And because I know that a couple of folks on here are also our MACE partners, I'll do a shout out that Jen and Effective School Solutions is also a new MACE business partner. So I know when you see her at the conference, you will go and thank her and welcome her to the groups. Anything else for the good of the group while we're here?
Not on my end. I just really
All
appreciate
right.
everybody's time.
Very much so. Thanks for being here. Dave did add an evaluation in the chat. So if there are feedback that you'd like to offer, please do so. And thanks so much for being here today with us, Jen.
Thanks. My pleasure. Thank you all.
Bye, everybody.